Hello, everyone. Welcome to our webinar, Understanding Cutaneous Reactions in Advanced Cancer Treatments. I'm Jasmine McGowan, our Managing Director here at Save Your Skin Foundation. Today, we're delving into the topic of skin toxicity and how treatments can affect the skin with our esteemed speaker, Dr. Joël Claveau. Before we begin, I'll keep it very brief. I want to introduce you guys to our foundation for those that may not be super familiar with us. Save Your Skin is a national patient-led non-for-profit dedicated to supporting those affected by melanomas and skin cancers across Canada. I also want to express our gratitude to the sponsors of today's webinar because without them, this webinar wouldn't be possible. I want to give a thank you to Merck and La Roche Posay for supporting this webinar and supporting all of Save Your Skin's endeavors. Now, like I said, I won't take up too much of your time. I would like to introduce Dr. Joël Claveau, a dermatologist based in the Ville de Quebec, and he brings a wealth of expertise in diagnosing and treating melanoma and skin cancers. As an associate professor at Laval University, he has completed his medical studies and internal medicine training and followed a residency in dermatology at the McGill University. Dr. Claveau's contributions to the field have been recognized with numerous accolades, including awards from the Canadian Dermatology Association since 1996. He was directed the Melanoma and Skin Cancer Clinic in Quebec, where he focused on prevention efforts and conducts clinical research in advanced melanoma. He's also an exceptional speaker, so I hope you get to enjoy our webinar today. So without further ado, I'm going to stop sharing my screen and I'm going to hand it over to you, Dr. Claveau.
Hello, everyone. Good evening. Thanks for having me. Do you see my screen well?
You're good.
Thank you very much, Jasmine, for the nice introduction. Thank you very much, Kathy, for inviting me and everything you've done in the world of melanoma and skin cancer. We've seen again this weekend at the Canadian Melanoma Conference how important your work and the work of patients to support patients is important. We, with the collaboration of Merck Canada and La Roche Posay, we have put together this program to help the patient to cope with their skin side effect of different treatment, not only melanoma, sometimes might be side effects of treatment for other cancers. So we'll cover that. I have this picture of a lady receiving a treatment in her vein. Often that's the case. Most of the treatment we have, immunotherapy is given intravenously, might be given subcutaneous in the future. Of course, for targeted therapy, we have pills now in many different cancers, so we'll cover that. I'm working in Quebec City at the Oncology Center and Melanoma Clinic. So again, thank you to La Roche Posay, who has put together a very comprehensive program to help the patient with their skin. We will cover that during my talk. And Merck Canada involved in immunotherapy with pembrolizumab for many years and very active in giving access to new treatments to treat various types of cancer. Now we have 25 indications for immunotherapy. Anti-PD-1. So the objective of the presentation is really to help and maybe just an overview to recognize and also talk about the various skin conditions associated with oncologic treatments, identify the best strategies to prevent. I think as a patient, I notice those days the patients are so involved in their treatment, they want to understand, they want to prevent side effects. So we really want to have you, the patient, understand what can happen. And also, the more you know, the more questions you can ask, it's better your collaboration will be with the treating physician. Very rarely, those treatments, especially immunotherapy, might become very severe. We don't want to frighten nobody about that. It's rare, but I think as a patient, you have the role of explaining and looking for those severity signs and call your doctor, nurse, pharmacist involved in your care when something goes bad. So the outline, a brief introduction about cancer in Canada. And right away from the beginning, I would explain what is a sign of severity. Actually, just arriving from the hospital right now, I've seen a couple of patients with skin rash skin eruption from medication today. And it's always the same. When we see a patient, either myself or in collaboration with the physician, the resident working with me, I tell them, okay, do you see sign of severity? And if we don't, then we can be reassuring the patient. I will talk a bit about the different treatment we have for when we have cancer. Chemo, radiotherapy are the oldest treatment. We still use that in many different cancer. But really what is new in the last 5 years, 10 years, is really targeted therapy and immunotherapy. And it's changing all the time. We have various treatments coming up, new combinations. So it's very important that we understand what can happen in your skin and know when it's time to ask help from your treating team, as I mentioned, your pharmacist, nurse, and doctors. Management and summary. So this is just an introduction, and I will cover that later on during my talk. It's the number one cause of death now in Canada. It's estimated that 225,000 Canadians are diagnosed with cancer every year, even more, 250,000. 1 out of 2 Canadians will develop a cancer during their lifetime, and unfortunately, about 100,000 people will die. So 1 out of 4 Canadians will die from cancer. The survival is still 63%. It's much better than it was, but still it's a very, very big concern you see in oncologic center all across the country. If we look at cancer incidence across various countries, you see Canada is way up there. Why? Maybe because we have a good, even though it's not perfect, we have a good health system and we have access, so we treat and we diagnose cancer. Also, maybe because of our lifestyle. Maybe in the past we used to smoke a lot. That's why we have still a lot of lung cancer. So you see, Australia, New Zealand, United States, Canada, Belgium, France, the big leaders in cancer. What are the most frequent cancer that we have? Lung, still the number one. Women more than before. Women have now smoking more than before, but fortunately, the smoking rate is decreasing. I saw a nice report recently in Quebec. It was like 40% smoking 30 years ago, and now 12% of the population. So good. That's a good point. But still, lung cancer is a big problem. Lung Institute, very busy. Breast cancer, number one in women. Prostate cancer in men. And the fourth one is colorectal cancer. So you see about half of the cancer are those four: lung, breast, prostate, and colorectal. And as I said, 100,000 people will die from cancer in Canada every year. The good news, yes, cancer incidence is increasing, but the treatments are better and the mortality rate are decreasing. More Canadians are living or are survivors from their cancer, and the survival is better. So what is giving us is now cancer is almost a chronic disease, and more Canadians have been treated for cancers before and have sequela of their anti-cancer treatment. Skin is a big side effect. Cutaneous toxicity, often when you question the patient, they will tell you it's the number one side effects that bother me. On top of that, chemotherapy, you lose your hair. Affects your quality of life, affects your adherence to treatment, a lot of psychological effect. And the good news, the more side effects you have, often it will tell you you will respond better to your treatment. When you have various types of cancer, we've talked about breast cancer, we've talked about lung cancer, prostate, various treatments are available. Sometimes you will have radiotherapy, after you will have chemo, and then surgery. Sometimes the opposite, you will have surgery, and then a few months later, you will start on adjuvant therapy, sometimes chemo, sometimes immunotherapy, sometimes targeted therapy. So various types of treatment according to the cancer you have, and this is why we have so many different various side effects. When you have the diagnosis of cancer, you are stressed. If you online, you have had the diagnosis of cancer or melanoma, you know how stressful it is at the beginning, and you have to repeat to us because we tell the diagnosis so frequently that we tend to forget how stressful it is as an experience. So often when we explain the side effects, chemo, immunotherapy, targeted therapy, we tell, okay, you will have arthritis, you may have arthritis, you may have diarrhea, you may have vomiting, nausea, vomiting, lose your hair, but we often don't talk about skin. We tend to forget about that. But patient telling us that 70% of the time, the worst side effects they had was on their skin. So it might be underestimated the importance of skin, but when we ask the patient in surveys, often it's telling us what is affecting more their quality of life is skin issues, either skin rash, pruritus, itchiness, or hair loss. So let's now make an overview, and not the goal to this is not to give like a perfect revision of every side effect, but we're going to cover quite a good number. It's not new that we talk about that. In the past, chemotherapy was the classic side effects. When I used to do my clinic at the hospital on the Wednesday, I used to see a couple of patients every week having side effects come from chemo. But now we have other treatment we call targeted therapy or immunotherapy. So chemo still used. Radiotherapy often will burn locally. Let's say it's the breast or the neck. You will have what we call radiodermatitis. So you will have inflammation locally. But now with all the new treatments coming up, targeted therapy, monoclonal antibodies, or sometimes small molecule, you will act directly on some receptor on the cancer cell, and you will give side effects. Sometimes the targeted therapy is an effect on the microenvironment, so locally, and immunotherapy boosts the immune system. Chemo, you have often a skin rash, desquamation, dryness, hair loss. This is a big table of all the side effects that you can have with chemo, but you see the number one is really losing your hair and dry skin and pruritus. Various types of chemo, many chemos here, different types of side effects. Hair loss, redness on the skin, ulcers, sensibility to sun, problem with the mouth. Frequently, the patient on chemo, they have ulceration in the mouth. You will need to give some special mixture to rinse the mouth with cortisone and antibiotics, antifungal. So often with chemo, you have redness like that. It may look like a, let's say, viral rash, will last a couple of days, sometimes a few weeks. Sometimes may look like urticaria. Some chemotherapy give you some urticaria like that. It's not dangerous, but it's really bothersome. But the classic with the new chemos we give, like taxane for breast cancer, is redness in the palms and so we call hand and foot syndrome. It's very painful. It will then become very dry and some with calluses, fissures, very uncomfortable. Radiotherapy, we don't need to talk a lot about it, just to mention that it's almost every patient that have a radiotherapy, let's say on the neck or the breast, or let's say for prostate cancer, they will have a burning of their skin, will start a few days after the beginning, limited to the area where it's treated, and usually the radio-oncologist will treat you with cortisone cream. At the beginning, you have redness, desquamation, it's moist, but later on, you may have like atrophy, you may have telangiectasia, pigmentation. So this is a chronic, the acute side effect, redness on the right. But with time, you will have like what we call poikiloderma, so the skin becomes thin and redness and brown, atrophy. Targeted therapy. If you have had this treatment, you know about it. If not, there is many cancers now that we have some specific antibodies. Sometimes it's a small molecule that will go at different sites. Complicated schema. I don't want to explain all of that, but just to explain you that the research now has brought some new information that we can block inside the cancer cell at many different sites, let's say BRAF, RAS, ERK, and then it will kill the cancer cell that will die and the cancer will disappear. This is what is used also, let's say, for head and neck cancer and HER, receptors for breast cancer. So many different targets, and now on oncology, we have different molecules to block that, and it's very efficient and very useful. There is different mechanism of action. Most of the time is a monoclonal antibody that goes against those receptors, EGFR, HER2, etc. And then by doing that, it will block the replication of the cancer cell and the cancer cell will stop growing. Sometimes not an antibody, it's a small molecule developed by research. So they have developed, let's say, a molecule that blocks the RAF receptor. They have developed a molecule that blocks the MEK receptor. EGFR, those are more frequent, let's say, in lung cancer. So this is melanoma, this is neurofibromatosis, and this is lung cancer. Same thing. So not to go too much in detail, depending on your cancer that you have, you may have a mutation in your cancer. In melanoma, it's the BRAF mutation. So if you have had the diagnosis of more severe melanoma, most likely your doctor have told you that you have the mutation BRAF or not. And if you have this mutation in your cancer, in the future, you will be able to receive anti-BRAF et anti-MEK medication to control your melanoma. My mouse is fragile, I apologize. I'll go slow. For head and neck cancer, it's EGFR. And for other cancers, sometimes even types of leukemia, it's c-KIT. So really, we act on various points to stimulate the immune system and get rid of the cancer cell. So in melanoma, I don't know if people online have BRAF mutation. If you do, you may have the treatment, and one side effect that you have, it's very dry skin. So every patient treated for advanced melanoma should be using moisturizing, should decrease soap, should decrease strong irritants, because they will have a dry skin like you just see. It was even worse when we asked those patients treated with anti-BRAF medication. So for patients that receive targeted therapy, it's very important you see your podiatrist, you use moisturizer with urea on the palms and soles, and use, let's say, like comfortable shoes, like running shoes and things like that, because when it's become so thick, it will be very painful. To give targeted therapy alone, and we used to have warts like that, and skin tags, and small skin cancer. But now that we use combination anti-BRAF, anti-MEK, we don't get those almost never anymore. We used to give a treatment called vemurafenib. It was the commercial name Zelboraf, and a lot of patients got burned. They got what we call phototoxicity. So fortunately, now we have new treatments, dabrafenib, tramitinib, or encorafenib, binimetinib, that don't have this side effect. I don't know, online we have person who treated with head and neck cancer, but it's different treatment. It's what we call AGFR, and some colon cancer treated with that now. And those treatment often blocks at the same thing at the receptor for AGF. And those patients, they will get a kind of acne on the face, and later on, they will develop pigmentation change and dry skin, fissure, cracks. So really, this is very important to know that those side effects, folliculitis-like, it's like a little bit like acne, and we see that with EGFR, it's a very frequent side effects. And the good news, and if you get that, you will respond better. So every skin rash, we encourage to use moisturizer, decrease soaps, decrease strong irritating products, avoid to play with the pimples, and often we will give patient minocycline, $100, 100 milligram per day, very rarely 200 milligram. And the oncologists often, they will give the treatment right away without even asking the dermatologist. This is complicated. I don't want to get too much in detail, but if you are receiving those treatments, you will receive either mild cortisone cream, a topical antibiotic, and antibiotic of the tetracycline, minocycline, doxycycline group. When you get eruption, you have more chance to respond to your treatment. It's the same with immunotherapy. The recommendation for the patient often is try to be gentle with your skin. It's winter, even though it's so not as cold as before. If you're listening in Winnipeg, it's probably still cold tonight. Dry climate, dry environment. We have to decrease the length of our bath shower. We have to be more gentle, use moisturizer. Maybe not 3 or 4 times a day, maybe you're good for that, but at least twice a day in a good amount. And yes, it's good to drink, but it's not the water you drink that will go to your skin to moisturize your skin. Is really what you apply on your skin. So hot water, frequent and long bath or shower, decrease irritative product on your skin. Very important to be gentle. Another side effects is problem with nails, ingrown nails, infection, really difficult to manage. You have to be very gentle in cutting your nail, have large shoes, and if you have no choice, you have to see a doctor who will give you cortisone cream, antibiotics sometimes. As you see, it's not a side effect of immunotherapy. This is a side effect of targeted therapy, EGFR, cetuximab, panitumumab, those treatments, panitumumab used in colon cancer. Same as I mentioned for nails, try to avoid playing too much with the nail. Large shoes, good hygiene of the nails. Cortisone cream and antibiotic, and let's say sometime you will have like Javel soaks, bleach soaks. When the patient received targeted therapy for many months, they develop calluses, may be terrible, difficulty to walk, painful. So something to be aware. Another example. Good shoes. Use moisturizer containing urea. So a product like that, like let's say Uremol, Eucerin contain urea, and have good shoes and try maybe to see the podiatrist if you are not able to remove the calluses. It's a treatment we give often with some types of leukemia, anti-sekit, and the side effect which is frequent is edema around the eyes. It's not really a skin side effect, but it's a superficial manifestation you see with swollen eyes. Finally, if we jump to the new treatments, I would like to make an overview of the side effects we see with immunotherapy. And we have not to forget that immunotherapy is used in advanced unresectable or stage 4 melanoma. It's used as adjuvant treatment for stage 3. It's now recommended for adjuvant treatment in stage 2B, 2C. And even now we will use immunotherapy sometime before surgery, we call neoadjuvant. So really the mainstay of treatment of melanoma those days. The treatments we use are blocking the receptor on the lymphocyte to stimulate them. Ipilimumab was the first one. now combined with nivolumab or pamrevlumab or cemiplimab alone. And the new kid on the block is relatlimab, which is another checkpoint inhibitor that is combined with nivolumab. So depending where you are in your melanoma, you may have received double immunotherapy, simple immunotherapy. You may have received it in prevention or treatment of metastatic disease. There's another category we call anti-PD-L1. It's more in lung cancer or sometimes Merkel cell carcinoma or kidney cancer. Okay, what's happening? A skin rash. The skin rash is not specific. I will show you different types of skin rash, but it's even 40% of every patient on immunotherapy that will have a skin eruption or dryness. So very frequent, and of course more frequent if you use the combo Ipi-Nivo. The different types of eruption we get, we call maculopapular, we call lichen planus or psoriasis. You can become itchy, and finally, it's a good news when you change your color of your skin, vitiligo develops. It's also a side effect. I don't know if some of you online have received immunotherapy for your cancer, but you were told by your doctor, often you're stressed, you don't remember everything, that you can have many side effects because you create inflammation in the body. And the most frequent is thyroid disease, the skin rash, and sometimes colitis, so diarrhea. And on top of that, you can have problem of your thyroid gland. So often the patient, you have to follow carefully the thyroid blood test. For lung cancer, they get a lot of the pneumonitis. So it's important that you know that when you receive immunotherapy, the side effects can be at the beginning. You see, everything is at the first few months, but sometimes you can have an eruption, you can have a thyroid problem, you can have diarrhea 5, 6, 1 year, 6 months, or 1 year after the treatment. So be aware of that. And if something's happened, don't hesitate to tell your doctor, I received immunotherapy before, so it will help. Again, there is good news. Not everything is bad. When you have a side effect, you often have a better response to your treatment. And this was shown in that paper, also was shown for vitiligo. Okay. In collaboration with many other doctors across Canada, we have done work to try to guide the doctors and maybe guide the pharmacists, the nurses, the patient, what to look for when you have a treatment with immunotherapy and what are the side effects you can have. You can have dry skin pruritus, you can have morbilliform eruption, eczema, lichen planus, psoriasis. This is normal. It's just a dry skin, but it's not normal to itch and scratch like that. What I mean, if you don't have nothing on your skin except dry and you scratch. And this can become a big problem. It can be very difficult to treat. I've seen another case today. It's the patient on immunotherapy, often an elderly patient, and he gets eczema. So often a patient that have had eczema before as a teenager or infant, and with immunotherapy, it will change the immune system and give those plaques of eczema where you need a lot of cortisone cream. This is rare. It's called lichen planus. It's a side effect that we see again with immunotherapy. You see compared to psoriasis, which is elbows and knees, this is more the palms and soles. This is another small lichen planus. It's very itchy. It's more itchy than psoriasis. So when I see a patient with this, I have to think, is it related to the immunotherapy that the patient is receiving? And often it is the case. If you discolorate your skin, this is good. This is a sign you will respond better to the treatment immunotherapy. Often, sometimes the patients are not happy, but it's often a price to pay. So we're almost done. I didn't want to go too much in detail, but I at least make an overview of the various side effects we can have with radio, chemio, targeted, and immunotherapy. And just to tell you a small tricks, again, if it's the prevention you want, we need to give good management tricks, good counseling to the patient to decrease soap, decrease length of bath and shower, and use moisturizer in the summertime sun protection. So really the three cornerstone of prevention is good hygiene, gentle soap, smaller shower or bath, moisturizer, and sun protection. Any types of treatment you give, from radio to surgery, immune, hormonal, the same rule applies. Then, after you've told your patient, okay, often can be the nurse, the pharmacist telling that, you will have to be gentle with your skin. You're going to have a dry skin. Even if you don't have a skin rash right now, start to use moisturizer right away. You may prevent the development of eczema. In the summer, you have to protect your skin. And now we have some more evidence that the more gentle you are with your skin, the less side effects you have. Then look for severity sign. When it's bad, it's when you have a fever, your skin is painful, you have some blisters, you have involvement of the mouth or the mucosa or the eye. Then this is bad. So this is something we repeat all the time to the resident. We repeat to the ICU. We tell the patient, even if you don't feel well, you have pain, you have a bad skin rash with blisters, affect your mouth or genitals mucosa, come and see us. Call your doctor, call your nurse, go to emergency room if it goes too fast. Another thing, when you have side effects of immunotherapy, often your doctor will give you, let's say, cortisone by mouth for inflammation of the colon, colitis, inflammation of the liver, inflammation of the lung. But the more cortisone cream we give, the less good we are with our treatment. So this is something we need to teach again to the doctor, not to go too fast on cortisone by mouth. So I told many times during the session tonight, moisturize, 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 decrease soap. If you have a skin eruption, it's itchy, you will need to use steroid, cortisone, topical steroids, moderate strength, large amount. Yes, you can use antihistamine at night, often the non-sedating, there is a couple that are not sedating, like, for example, Reactine, and sometimes the new one, Rupall, and others. It's rare now that we stop immunotherapy. We better interrupt for a couple of treatments. Sometimes if we need cortisone by mouth, but then we can resume. This is the big jar of cortisone that we give the patient. I prescribe 3 times this today. Why? Because you need to cover in a good amount, large amount, for 1 week. Let's make it clear, cortisone cream is not dangerous on your skin, except if you use for months and months. And as far as the face, you can, or neck, you use milder cortisone like hydrocortisone 1%. It's sold in the pharmacy without prescription. People asking me what is the best moisturizer, and my political answer is the moisturizer the patient likes. There is many of good moisturizer you see here. Of course, we have worked in collaboration with La Roche Posay. We like to recommend their products. L'Epicard Balm, it's anti-edema, anti-pruritus also, but there is other options too. So we've covered it all. Oncology patient is the same as other patient. You can have different side effects. The skin is the #1 side effects. Up to 50% of every type of treatment for cancer, radiation, chemo, immunotargeted therapy will have skin side effects. It has a major impact on quality of life, and it has to be addressed. Even if you are the patient, you can help us to tell us it's bad. When you don't feel well, it burns your skin, you have blisters, then it's good that you look for help because it might be a life-threatening side effect. Recognize the most frequent cutaneous side effects. Avoid systemic cortisone by mouth because it may not ruin, but may delay our treatment with immunotherapy. And finally, how do we prevent? Decrease soap, decrease long bath and showers right after moisturizer, cotton clothes, decrease the washing or decrease at least the softeners. And if it's starting to be bad, then we need to use cortisone, mild on the face, moderate on trunk and limbs. Okay, so we still have 15 minutes. This is nice Quebec City. It's not now, even though the snow is melting very fast. And thanks for having me, and hope to see you sometimes in Quebec City in other occasions.
Amazing. Well, thank you so much. I have implemented the moisturize, moisturize, moisturize into my routine now. I'm going to think about it all the time. Dr. Claveau, thank you so much for your presentation today. You were exceptional. Finally, I want to thank Merck and La Roche Posay once more for sponsoring this event. Thanks to them, we were able to bring this over to all of you and to all our online folks. Thank you so much for giving an hour out of your time. I hope you learned something, got your answers, questions. If there's any additional questions you might have, feel free to send me an email and I will connect you with Dr. Claveau, depending on what it is. We have a variety of resources on our website, saveyourskin.ca or sauvetappeau.ca. Again, a big thank you, Dr. Claveau, as always. You've been incredible, and I wish everyone a lovely night. Thank you so much, everyone. Bye-bye.
Thank you, everyone, for your participation and your commitment to help the patient across Canada. And yes, you will find some information on the website about that. We'll try to make some summaries and give good advice to our colleagues. Thank you.
Thank you. Bye-bye, everyone.